We've done the studies. It's very reliable. If you do a pap smear and then do a biopsy afterwards, if the pap smear is abnormal, very reliably we have find abnormalities on the biopsy. So it's a good test. And then the concept is that you're supposed to go and do subsequent higher resolution anoscopy, which is the colposcopy of the bottom, and then do the same things that the gynecologist taught us. Put a little bit of acid on there, put a little bit of iodine with the Logol solution, and look for abnormal areas, and then destroy the abnormal areas. The problem, the difference that we have is it's relatively easier for the gynecologist to take care of the neoplastic lesions of the cervix. And so the difficulty we have is that it often requires extensive multiple surgeries with difficult, painful recoveries. And these people take a couple of months to get back to life after you do some of these very extensive anal excisions. So it is a bit more of a difficult problem. The other problem we come up with is that there's a couple studies out there when they've taken 29 patients with AIM3 or high-grade intraepithelial dysplasia, they eradicated it, they think they got rid of everything. They look back a year later, and 23 out of the 29 had AIM3 again. And this kind of speaks to the field effect and perhaps sampling errors and those kinds of things of looking at the entire anoderm. So it is a little bit difficult to eradicate the dysplasia, not just the HPV virus, but the dysplasia that's going on there. So that has really led to two kinds of camps that have come out in the treatment of dysplasia of the HIV-positive anal butt. One paper that caused a lot of stir was Welton and Palevsky's paper out of San Francisco that came out in 2008. They reported 10-year experience of aggressive management of anal high-grade dysplasia. And what they did is they reported 246 patients. And they made a big brouhaha and traveled and talked about it. The problem is I'm going to take the study apart a little bit. I'm not saying it's not correct. I'm just saying that there are some problems with the study. And the first problem is they reported 246 patients. Unfortunately, only 182 of them were HIV positive, which is really what we're interested in with the majority of the studies. I don't think you can compare HIV positive and HIV negative patients. They seem to act differently. The other problem is that 14 of them had squamous cell carcinoma in the first biopsy, so they're thrown out. They don't get any more, they don't get to develop cancer because they've already got it. So it really brings down to 164 patients. The problem throughout the study, though, is that they continued to use the 246 denominator on just about everything that they did. And so that washed the numbers down a little bit. The final number they came up with is a 1.2% progression to cancer if you aggressively follow these people. But this is what it took to aggressively treat these people. After their initial thing, whatever it was, destruction, excision, the operating room, whatever, only 39% didn't have to have anything else done. The other 60% had to have something else done. 46% of those had to have things in the office a few times, maybe some destruction, freezing, whatever in the office. 9% of them had to have a major reoperation, and then 4% and 2% had to have more and more reoperations. So it really does take a lot to get rid of this stuff in most patients, and it seems to keep coming back. So that's a lot of pain and cost and anesthesia. If you look at the subset that they report, which they looked at 246 patients, which remember is really 164. 46 of those patients said you have pretty extensive stuff, which is what we deal with most of the time in the colorectal world. And Richard, as you said in your world, it's more extensive stuff. That's the patients we're really interested in. We can do okay with a couple of warts. We want the extensive stuff. Only 34 out of the 46 completed their stage procedures, meaning the rest of them walked in and said, I've had enough. I'm not going to do what you're telling me to the end. So it really is a painful, time-consuming thing. Of the ones that completed it, 3% had squamous cell carcinoma initially, and after their first excision, they found squamous cell, and then another 5.8% got squamous cell carcinoma while they watched them. So really, you could say somewhere between 5.8 and 8.8% of their patients developed cancer on this protocol as they're going through it. So the highest risk patient seems to be a little higher than that. And then the biggest problem with the study is there's no control group. They didn't have a group of people that they watched and didn't do anything to and see what happens. So we got to look somewhere else in the literature for this, and we looked to San Diego at Bard Cosman, who reported his patients, where his study was, you send me a patient that's got dysplasia on biopsy or cytology, what I'm going to do is I'm going to examine the patient, and if I don't see anything that worries me, I don't see any lumps, bumps, anything in there at all that worries me, I'm just going to tell them to come back in 6 months, and I'm going to examine them again. If I see anything that worries me, I'm going to go take it out. I'm going to take it to the operating room or in the office, depending on how big it is, what it is. I'm going to take it out, destroy it, send it off to pathology. And when I've destroyed everything that's abnormal, I'm putting you back into the surveillance. And then, of course, if you develop cancer, then we're going to treat your cancer and get out of there. And when he did this over 3 years rather than over 10 years, he ended up with about a 7.5% conversion of squamous cell carcinoma. Not that much different than what these people are talking about when they do very aggressive stuff. And even if you take the very aggressive stuff and say it's 1.2%, is it worth all the pain, recovery, and everything else to drop the rate from 7.5% to 1.2% for cancer that actually is relatively treatable and curable? You're going to cure 80% of these people when they develop the cancer. So there's a lot of debate still going on. A lot of people are still asking what the right treatment is. Should we be getting very aggressive? Should we be sitting back? My personal philosophy is I sit back. I'm more of San Diego than San Francisco influence. I do ask my patients to come back every 6 months with high-grade dysplasia. If I see anything that develops, I'll take them and destroy it and keep following. When we looked at our study, and we actually have had very, very few people advance to this, the problem with this approach is they don't follow up all the time. So the people are supposed to come back in 6 months don't. The cancers we've had develop are people who have disappeared for 3 or 4 years and then come back with a painful lump. So that's it. But on the other hand, the argument against that is when you cut it out a year later, most of them have AIN3 again anyway. So again, it's an evolving issue. We'll see where it ends up. It may not ever be resolved. A bit of a controversial area. Anal cancer, these are all different anal cancers. No-brainer diagnosis, right? If somebody has a pain and a suspicious bump, you got to biopsy it. You're not doing anybody any favors by just watching and see if it'll go away. Just really go in there and biopsy, get rid of it. Anal cancer incidences, 0.7 per 100,000 back in 82. It hasn't changed that much, stayed about the same. It's a bit up in homosexual men at that time. Once we get to the HIV positive homosexual male, 84 in this study, most people say about 100 times more likely to develop anal cancer if you're an HIV positive male than if you're an HIV negative male, part of the general population. So it really is a much higher risk, which is why we're doing all this education, why we're doing the pap smearing and everything else to try to control this. Very high incidences. This is my own study, my own patients. I shouldn't say it's not really a study. I was seeing 2 to 4 patients per year with anal cancer. All of a sudden in 06, 07, and it's actually kept up in 09 and 10. Now we're getting up to 8, 10 a year that we're seeing through. It could be that I'm just getting more known out there and people are sending more of their complicated stuff to me, but there's other studies nationally that show the same trend. You can see an increase in anal cancer over the years as it's been coming up. The explanation for this seems to lie in the time frames of what we're talking about. Richard talked about this in his study. I'm just repeating Richard's talk. It's all the same stuff. He talked about the lag phase of developing cancer being 10 to 15 years. Most cancers are in there. Cervical cancer, I think you said 20 years, 25 years? 25 years can happen in there. What we're saying is when you look at the patients that are HIV positive, that are coming back with cancers, you're starting to get some clues that we may be seeing the same thing. So this study out of Texas, when they looked at the age, CD4 counts, and viral titers of the patients who just had dysplasia versus invasive cancer, no difference. But what they found was that if you had dysplasia, the average duration of HIV positivity was 6 years. If you had cancer, it was 13 years. So the cancers had HIV for a longer time period. Maybe that lag phase that we're talking about. Our own study that we published, actually most of these were done at this hospital. We looked at 853 warts that came out. This is, about 15% dysplasia, which works pretty well in the warts, it jives well with the literature. When we broke it down, if you've had your HIV for less than 3 years, only 12% had dysplasia. If you had HIV for more than 15 years, 30% of them had dysplasia in it. So again, it seems to be a time frame difference of increased dysplasia, increasing cancers. What that really means for those of us in the business that are dealing with this is we're getting a little bit scared. We think that we may be just at the beginning of a wave of even a bigger, huger number of anal cancers that are coming, because now we've had HIV for 15, 20 years, and we may be seeing that lag phase come into fruition. And we're having more and more people live with the disease. It used to be unheard of to have somebody that lived for 5, 6 years with HIV. Now, my office is full of people who were diagnosed in 1985. It's huge. They're living longer for whatever reason. You can argue whether the drugs are better or whether this is acting like every parasitic disease, which is the virulent forms kill their host, and so what you're left behind is the less virulent forms. You live more with the disease. In any case, we're seeing much more longevity to the patients. I'm not going to talk about vaccines at all because Richard did. The only thing I'm going to say is which Richard did anyway. There is the numbers. I'm not going to go through details, but they show that once you're infected with it in the HIV patients, it's not going to get you uninfected by injecting the vaccine or vaccinating yourself. So nothing else. Any questions on the HIV or the male HPV?